So good afternoon. I'm Randy Kearns, your professor for Healthcare Management 2000. And um, since our class was interrupted because of thunderstorm the other night, I'm going to re-record the finance and insurance component and post it today. And today being Thursday, the 18th. So a couple of things that I want to be sure and mention. Again, assignments for this week. There's a short reaction paper, 500 to 700 words. Be sure and use the APA formatting. I posted a paper example. Be sure and make yours look very similar to that. If you've taken an English course before, or a history course, or a religion, you may have used MLA formatting. Just understand in the business school we should be using APA formatting, which is a little bit different. And again, be sure to use the appropriate formatting style. Certainly, if you have any questions, send me an email about that. But let me go ahead and get started with the presentation itself. The only other thing that's due this week, in addition to the short reaction paper, there's no online chat discussion that's due this week because of the paper. There is a quiz that's due this week, 46 questions, and you have 75 minutes to complete it. Let me go ahead and start by sharing this screen. And sorry, hang on just a second. Okay. Now we're ready to go. As far as the terms go, I don't want to spend a lot of time here because all of these terms reappear in the context, but I will tell you to come back and spend a little bit of time looking over these terms in regard to how you understand the way they're used. The main focus that I'm going to emphasize will include a little bit more of the private insurance and the commercial insurance part. The government insurance, Medicare and Medicaid, we've talked a lot about. I'll mention it again, but only briefly. And then I do want to spend a little bit more time talking specifically about what managed care is, and then the difference between an HMO or a PPO. And then again, to talk specifically about insurance. This is the one particular lecture where I spend the most time talking about insurance and how insurance works. So again, as far as how we finance healthcare, we finance healthcare in America in a little bit different way. As I mentioned before, I don't think there's a country tomorrow that would wake up tomorrow and say, let's do it exactly the way the Americans do, because it is fragmented. We wind up with a lot of different rules, and because there's a lot of different rules, we spend between 20 and 22% of all dollars in healthcare in the administrative function. That's collecting, billing, satisfying the bill, and archiving old debt. That's vastly more than most countries. Actually, that's vastly more than anybody else. As an example, in Canada, where they have a single payer system, and oddly enough, their single payer system is called Medicare, they spend between 3 and 4%. And again, we spend just north of 20%. So again, I'm not going to try and defend it and tell you that it's the greatest thing in the world. And I also won't tell you that I would strongly encourage us to immediately abandon this and try and go to a single payer system, just simply because of how challenging I think that would be as well. But that's for another lecture at another day. It is important to break things apart into, there's really three groups of payers. The largest is the commercial or private insurance payer, but very similar in size and scope and the amount of money spent is the government payer, and that's Medicare and Medicaid. And then the third group is a smaller group, and that's the self-pay or uncompensated care, what people pay out of pocket for healthcare. And there's far less that is paid out of pocket than is paid by either insurance, whether it's government insurance or commercial insurance. But it does exist, and to some extent, it can be a significant amount of money when you're talking about total revenue being $1 billion each year for a lot of larger healthcare systems. Obviously, the out-of-pocket payment is in the millions. So this just gives us a kind of a comparison that self-pays about 10% of the national health expense. And then Medicare and Medicaid represent just under 40%. Private insurance represents 34–35%. And then this other is kind of the mix of all of the little things that may be out there. Workman's comp would be one of them. Workman's comp is not really a commercial insurance, and it's a very slow payer source, but once you do collect that money, it's actually a very good payer source, but it takes a long time to process those claims. And then why is national health expenditure important? In terms of it being a percentage of GDP, our gross domestic product, again, as I mentioned before, GDP for the United States is about $22 trillion. That's a larger economy by far than any other country. The next closest economy is the Chinese economy. By some estimates, it's somewhere between 12 and $15 trillion. But again, compared to the American economy, that's north of 20 trillion. That's an enormous amount of money. But it also gives you an idea of just how much money we spend on healthcare as well. And because we spend so much money on healthcare, even small savings in terms of the percentage of GDP can yield significant amounts of releasing revenue that can be used for something else. If you'll notice before Medicare and Medicaid, how much of GDP was healthcare, it was 5%. By 1970, Medicare and Medicaid had been phased in most states. Not every state had accepted Medicaid, but Medicare was certainly prevalent everywhere. And then by 1980, Medicare and Medicaid was everywhere. Although there was great concern about how substantial healthcare had grown as a component of total expense. And then by 1990, 12%. Again, as you can tell, it was substantial growth. I will tell you, at each step along the way, economists predicted a lot of gloom and doom over, we can't possibly get to 10%, and then we can't possibly get to 12%, and then the argument was we can't possibly get to 15%. And now you will hear an economist say we can't possibly get to 20%, and if we do, how terrible it will be. I can't tell you I fully understand it, other than we've managed to embed it as a local expense, and because it does create a lot of local jobs, and it does create a lot of local investment. An economist will also tell you there's a churn factor. How many times a local dollar that's collected is spent locally and then is respent locally, and then how does that money churn in that local community, as opposed to buying a product that's created internationally where there's one or two transactions, and then a part of those dollars move to another country to pay for the purchase of that product. Anyway, fascinating economics discussion, not something we need to deal with today. The main point I will make, though, is if you'll look at the time the Affordable Care Act was passed, 2010, percentage of GDP for our health expense as a nation was about 17.4%. And even through 2018, the latest total year of numbers we have, 17.8%. It's remained mostly flat. Now, just understand during the same period of time, the economy has grown substantially. So while as a percentage of GDP, it has not grown, the total amount of money being spent on healthcare has continued to grow, again, substantially, just in keeping pace with how the American economy has grown substantially. And as I mentioned earlier, so the American economy is north of $20 trillion. Some would tell you 22 to 23 trillion. The Chinese economy is somewhere between 12 and 15 trillion. There's no other economy on the planet that's more than $10 trillion. So again, we spend money in a different way. We create money in a different way than the rest of the world. And so again, it's tough to completely compare what we do in America with what's done in other countries. I will tell you there are some estimates that it may be by 2026, it could be close to 20% of GDP. And it does remind us anything that we can do to shave some of the cost of healthcare allows us to invest that money in something else other than healthcare. There's an advantage to that if we're investing that locally. There's not so much an advantage to that if it just frees up money to buy something internationally that's just additional offshoring of dollars that, again, from an economic standpoint, isn't always absolutely helpful. Nothing really on this slide that stands out as terribly important, but let's go ahead and move into what insurance is, and then let's talk a little bit about insurance is a way that we can pool our money and share the risk. As an example, if you purchase a car and let's say you pay $20,000 for the car, well, certainly in my life, there was a time that $20,000 was a lot of money. Today, it's still a lot of money. But regardless, no matter what your frame of reference is, you don't want to just drive it down the street and suddenly somebody comes out of nowhere and runs into your car and damages it, and the damage is $10,000, you know, half the value of your car. How do you pay for that? You know, the advantage of sharing, of pooling our money and pooling, when we pool our money, we pool our risk as well. And that's the purpose of insurance. And so whether it's with your car or whether it's with your house or it's your health, the whole point to insurance is a way that we can all put our money into kind of a savings account, so to speak, and somebody can monitor how much money needs to be spent out of that account each year. And the test of that is actually something called actuarial soundness. I'll talk about that later, but the whole point of that is to be sure that if there's 100 of us who are buying health insurance, then 100 of us have to contribute enough money with the bet, the belief that most of us won't get sick, most of us won't need most of the money that's in the money that we pooled each year. But somebody will get sick and somebody may get deathly ill, and it may take a lot of money out of the pool. And somebody has to guard the money and protect it and determine how to invest it, and to be sure that they've collected enough money to pay for all of the claims. And we'll talk in just a minute about who those people are. Actually, I think it's coming up on the next slide. It is. So if I'm the person that has the insurance, I'm considered the insured. Okay, so I buy insurance, I'm the insured. If I buy insurance from somebody like Blue Cross and Blue Shield, they are the insurer. Okay, so I'm the insured, they're the insurer. And then the underwriter is somebody who's typically in another state who mathematically looks at all of the people who are in my risk pool. And that's today, because of the Affordable Care Act, we pooled large numbers of people together to try and balance that out a little bit more consistently. But the underwriter evaluates the risk and sets the rates based on that risk. So there's really three players here: the insured, the person who bought the insurance, the insurer, the person who sold the insurance, and then the underwriter. And the underwriter, again, is some mathematical genius or statistical somebody somewhere, probably 2 states away, who mathematically looks at how much money needs to be on hand all the time to pay out the claims and set the rates for the people who need to be insured. And it's also important to distinguish in terms of insured. If I'm the insured, I may be the enrollee, or I may be both the enrollee and beneficiary. And an example of this would be, so let's say I bought insurance. I work at the University of New Orleans. They provide me an opportunity to buy insurance, and I buy it for myself and also buy it for my wife. Well, I'm the enrollee. I'm also a beneficiary who's receiving benefits. My wife, who is also a beneficiary, may not be the enrollee, but she is a beneficiary because I'm enrolled. Just understand the person who bought the insurance is typically the enrollee, and then other people who may benefit from it, which could include the enrollee, is the beneficiary. So let's kind of move into the 4 key principles of insurance. Risk is unpredictable for individuals. Again, I get back to my car. I just paid $20,000 for it. I drove it into an intersection. The probability of me wrecking that car is very, very slim. And yet, when it happens, it goes from a very small percentage to 100%. Well, at that point, I want to be sure that I'm sharing that risk with a lot of other people so that my insurance doesn't go up a great deal. And the point is, risk is a lot easier to calculate for a large group of people. So we can predict what the risk will be for a larger group of people. It's unpredictable or far less predictable on an individual basis. And the whole purpose to insurance is to shift risk from me, the individual, to a larger group. And it allows us to pool resources. It also means that losses are shared by all of the members who have pooled their money together to create this pool for insurance. Now, there's 4 ways that insurance works to share cost between. Again, I get back to that pooling our money in a risk pool. That's really what insurance is. Well, there's 4 ways that you contribute to that fund of money. The first one is each month I pay a premium, and it's paid monthly. Sometimes it's paid only by the employer. Sometimes it's paid only by the enrollee or the participant. Sometimes it's a bit of both. The employer pays part and the enrollee pays part. But that's paid monthly, per member per month, or it's paid monthly. Deductibles occur once a year, and it starts at the first of the calendar year. And deductible is how much the enrollee needs to pay before the insurance kicks in and starts to provide coverage. If I'm the underwriter and I'm trying to keep the cost of the premium down, I may increase the size of the deductible. Some deductibles are very small. They may be $500, but my premium, the amount I pay each month is much higher. On the other hand, my deductible may be much higher. In fact, I'll give you an example in just a minute of a high deductible health plan where the deductible is $10,000, but the premium is very small. Okay, and so what you're doing is you're shifting risk from do we evaluate the risk based on the premium, or do we evaluate the risk based on the deductible? The larger the deductible, the more you put some of the decision making in the hands of the enrollee, the person who's insured. And then co-payments. Co-payment is per event, pre-event, meaning I go to the doctor's office and if I'm in that network and I get I'll pay $20 or $30, but I have to pay my copay before I can be seen, so long as it's not an emergency. So it's my flat fee out of pocket. It's per visit, pre-visit. So before the visit, before I get to see the doctor, I have to pay my copay. Co-insurance is what I pay after the visit. So let's talk about this just a minute. If a traditional insurance plan is called an 80-20 plan. It means that all covered services, the insurance will pay 80% of all covered services. So let's say the approved bill is $1,000 and I've already met my deductible. Of the co-insurance, my co-insurance will be 20% of $1,000. The insurance will pay 80% of $1,000, which is $800, and I'll have to pay the co-insurance, which is 20%, which is $200. Okay, let me say that again. If the approved amount for the services provided is $1,000 and I have an 80-20 plan, 80% of that is paid by the insurance, which is $800, and I have to pay the co-insurance, which is $200. One other thing just to be clear about also is co-insurance is based on the approved amount, not the gross amount. So when hospitals tell you you're going to get a bill, but don't worry about it early on until you get your EOB. EOB is explanation of benefits. That's from your insurance company. Once you do that, then we will tell you how much you still need to pay. I'll give you an example. We wound up with an emergency room visit several years ago. The visit was about $5,000, but the approved amount, so the gross bill was about $5,000, but the approved amount, that's the difference between what the hospital charges and what my insurance said, this is what we will pay you. The gross bill was $5,000. The approved amount was $2,000. So my co-insurance, what I have to pay is 20% of $2,000, not 20% of $5,000. And what my insurance paid is 80% of $2,000, not 80% of $5,000. And what happens to the other $3,000? The gross bill from the hospital versus the approved amount from the insurance company, that's what the hospital has to write off as an uncollectible debt. Group insurance, self-insurance, and individual private insurance. So with group insurance, that's typically a large group of employees that get together and their company or organization buys insurance. A typical example of group insurance would be if I worked at a hotel downtown. Chances are that's a group insurance because those hotels downtown are actually franchised, and they may be, you may have 5 or 6 hotels that's owned by one company, but not. In other words, if you see the name Marriott, it doesn't mean that Marriott owns all of those companies. In fact, it's more than likely one company may own several Marriotts, but that's all they own, and it's a smaller company that has a franchise to operate Marriott. My whole point there is he may have about, he or she who owns that company may have about 500 employees. They go out and buy a group policy, and everybody is able to buy is able to have insurance on that group policy. Self-insurance is where a really large employer actually puts a large chunk of money aside and hires an insurance company to oversee their insurance. An example of that would be the state of Louisiana. I work for the University of New Orleans, and I have a Blue Cross Blue Shield card of Louisiana, and it's provided to me as a benefit of being an employee. And if I look at that closely, I will realize I don't really have Blue Cross Blue Shield insurance, Blue Cross and Blue Shield administers the program of self-insurance by the state of Louisiana. And the one thing any large company does that does buy self-insurance, they actually buy a reinsurance, or high losses are covered each year by a reinsurance company. And the most common reinsurance company is a company called Lloyd's of London, where some of the more outlandish things you would insure, they cover that type of insurance. And then the third piece is individual private insurance. This market has actually grown substantially since the creation of the Affordable Care Act. It used to be really hit and miss. If you were very healthy, you could get fairly cheap insurance, but if you had a pre-existing condition, you generally couldn't buy insurance, or if you could, it was cost prohibitive. It just didn't make sense to buy insurance. What's happened with the Affordable Care Act is it created a marketplace, and all of those people are pooled together, and all of those people buy an insurance that's rated basically the same way. Now there's different plans you can buy, gold, silver, bronze, and platinum, and each of those provide different scales of coverage and different scales of cost. But the whole point is the individual market has grown fairly substantially since the creation of the Affordable Care Act. And the best way to think about the Affordable Care Act is in 2010, now mind you, there were a lot of people out of work, but in 2010, over 60 million Americans did not have insurance. And in 2016, at the end of the first 6 years of the Affordable Care Act, we'd gone from over 60 million Americans without insurance to about 17 million. Now, that's still too many people, particularly if you're one of those 17 million, but in a country of 325 million, that was the lowest number as a percentage since we started with Medicare and Medicaid in the 1960s. So managed care plans and high deductible health plans are the other two types. Managed care can be can range anywhere from something called an HMO, a health maintenance organization, which typically is not an insurance company, but it is operated somewhat as an insurance company, or a PPO, which is owned by an insurance company. But is kind of a hybrid version of an HMO. So let me explain the two. An HMO is typically not associated with an insurance company. And in fact, there was a time that the HMO market was really popular and had really moved into a lot of places. And to help combat that, insurance companies created the PPO to compete with the HMO. The challenge with an HMOs will typically give you the cheapest rates. The challenge with though is they use a gatekeeper model, meaning anything that you get that you need to have done, you need to see your primary care physician or talk with your primary care physician, who serves as a gatekeeper. And that primary care physician is typically under contract with the HMO to refer you to services in network. If you circumvent that, if you go outside of network, you may have to pay a substantial amount or all of the cost associated with it. It may not be covered at all. The point to an HMO is they negotiate steep discounts, but you have to be in the network. And if you're not in the network, you assume significant risk and significant liability. An insurance product is a little less punishing. They provide a little bit more reward with if you stay in network and use the PPO approved physicians and approved hospitals, you'll get a discount. You're typically not going to get as much a discount as you will with an HMO, but a PPO also offers you more options. An HMO has more limitations. And then the last one that has just become prominent is a high deductible health plan. And that's really a $10,000 health plan, but it allows companies to have very low premiums. And so, it's kind of that old adage of as long as you don't get sick, it's a great plan to have. If you get sick, the big challenge now has been to look to create solutions that help fill in that gap, because as I said, it's a high deductible, meaning every year you're responsible for the first $10,000 out of pocket. And so how do you pay for that? An HRA is one of those solutions. I'll talk about HRA, HSA, and FSA in just a minute, but those are ways that you can fill in the gap between what insurance covers and what insurance doesn't cover. The HRA is the employer version, and again, it was created to help fill in the gap with a high deductible health plan. Other medical insurance quirks that I think are certainly important for us to understand is the community rating and pure community rating. And the whole point to this is to understand that how healthy a given area is, or how unhealthy a given area is, does have some influence over what everyone pays, what the underwriter estimates needs to be collected for the services provided in that region. And an example of that, and a point to that, is if I certain parts of West Virginia, as an example, coal mine country, average life expectancy in some of those communities is in their 50s. They have a lot of chronic health conditions. If I'm an underwriter developing either a community rating, that has to be considered as a factor as you're trying to estimate total cost, and you're trying to estimate what premium should be as an underwriter. So trying to understand a little bit of what community rating means in terms of how it impacts premiums. Just understand that much larger geographical areas today have to be considered. Just in New Orleans, you can move from one zip code to another, and life expectancy is as much as 20 years difference between one zip code and another in the city of New Orleans. That speaks to a lot of health inequities that exist here, but that's not reflected in the insurance, because you can't, when we talk about community rating, you can't drill it down that close. Anyway, another piece that I do think is important, there's two other pieces here I want to be sure and mention. That's the birthday rule and the coordination of benefits. It may not be important to you in your job and your future, but these two pieces are important to you in your life. And let me give you an example. Let's say that that your birthday is July the 15th, and your spouse's birthday is March the 1st. Okay, and you've planned on having a baby. Now your spouse is pregnant, and she's going to deliver the baby in the first of the year. Okay, you both decide that you want to cover the baby on your insurance. So the spouse covers the baby, the dad covers the baby. Once the baby is born, whose insurance becomes the primary insurance? And you would think, because both of you have covered the baby, that well, there would be a coordination of benefits. Well, the coordination of benefits doesn't take effect when the birthday rule comes into effect. And what I mean by that is whoever was born first, and I'm talking about during that year. So again, as let's say the man, as an example, was born in July and was born 5 years before his wife and is older. It's not who was born first, it's whose birthday comes at the first of the year. And the reason that's important is you need to be sure that if the mother decides that if you both decide you're going to cover this child, whoever whoever was born first, that's the primary coverage for this child. If the mother has a high deductible health plan, you're responsible for that $10,000 out of pocket. Dad could have, or we could reverse this. Dad has a high deductible health plan and mom has great insurance, but mom can't, for whatever reason, doesn't cover the child, but dad decides to cover the child. That high deductible health plan is going to be, if you both covered it, it's whoever's birthday is first. If you both did not cover the child, then it's whoever covered the child. Coordination of benefits is when one person has two insurance policies. We see this a lot with particularly retired military personnel who have retired. They receive TRICARE for life, and TRICARE is a commercial insurance, a version of commercial insurance. And at the same time they go to work, let's say they go to work for the University of New Orleans, and as a state employee they get a Blue Cross card as a benefit. Well, so Blue Cross and TRICARE will have to coordinate benefits between the two of them to be sure that as much payment, you may still be required to pay some out-of-pocket cost, but it will be minimized because of coordination of benefits. But again, the birthday rule is an important thing to remember when you're thinking about family planning later on for you as an individual. It may also come into play in a job that you have. Now, this is not required by law, but it is something that's typically, if it's not specifically excluded in the state, the National Association of Insurance Commissioners have agreed that that is a process that they will follow. So it is important to understand what that means, what's the implication for you personally, and maybe what you may be doing in your work life too. So types of funding to offset healthcare cost. I mentioned this earlier when I talked about the HRA. There's really three different types of funding to help offset the cost. So I've mentioned before, premium is what you pay each month. Deductible, you pay one time a year. Co-insurance and co-payment. Co-payment is per visit, pre-visit, and co-insurance is per visit, post-visit. So after your care, you have to pay co-insurance. All of these things can be, so co-payment can be offset, co-insurance can be offset, and deductible can be offset by any of these three programs. FSA is employee only. It's a one-time thing you do once a year, or you do it each year, but at the end of the year, you have to spend all of the money. If you don't spend all of the money, whatever's left there does not roll over. That's reclaimed by the plan. So I have an FSA account. I keep close watch on it, and if November, December, I haven't spent most of the money, I look for eligible items that I can buy with the FSA money to be sure that I don't leave anything out there. HSA is that blend between employer and employee. And a lot of companies, the company will donate some money to the employee's HSA account, and the employee can put money in the HSA account. The advantage to an HSA is it does carry over, but not every health plan is eligible for HSA funding, and not every employer has HSA as an option. And then HRA is employer only, and is typically the big offset that most companies will provide for an HRA plan. They may give you $2,500 a year towards your HRA account. And if 4 years goes by, you haven't used any of that money, then you've got the $10,000 that will help with your deductible for your high deductible health plan. But the HRA money is only put in by the employer. The HSA money is put in typically by the employee and the employer. And the FSA is put in only by the employee. And then let's kind of move on to the Affordable Care Act and private insurance. There were really some big changes with the Affordable Care Act in terms of its impact on private insurance. One of those big changes includes how what essential health benefits are provided. So it clearly defined each insurance plan had to provide what's called essential health benefits. I'll show you those in just a minute. It also took away lifetime limits on benefits. And I'll give you an example of that in just a minute. And it also required, or in some cases recommended, preventative services. But there were some preventative services that were required as a part of the Affordable Care Act. Other components of the Affordable Care Act included extending coverage for children under their parents' insurance for up to their 26th year of age, which was really a big deal. Prior to the Affordable Care Act, it was after, before your 19th birthday, you had to come off of your parents' plan unless you were in college. If you were in college, you had to come off of your parents' plan before your 22nd birthday. So extending that to 26 was really a big deal. Another thing was requiring employers, if the employer has more than 50 employees, any employee that's working 30 hours or more per week must be provided health insurance. And then the health exchanges offers 4 categories of plans, as I mentioned before. They're called gold, silver, platinum, and bronze. It basically is varying premium levels. The other piece about the health exchanges was also a substantial subsidy to help offset the cost of that insurance. Really a big deal to, again, for people who did not qualify for Medicaid, but were considered the working poor and were challenged with being able to pay for their insurance, could get a subsidized, and in some cases a heavily subsidized private insurance policy from the marketplace. So I've talked about public insurance before. I'm not going to spend a lot of time on this, but Medicare and Medicaid, again, Medicare is primarily people 65 and older, end-stage renal disease, and people who are disabled. And of those 3 groups, by far and away, the largest group are those 65 and older. Medicaid is financially disadvantaged, and the children's version of Medicaid for children only is CHIP, or also known as SCHIP. And then other government healthcare, the Veterans Health, TRICARE, as I've mentioned before. There's some active duty military hospitals, Bureau of Indian Affairs, the Tribal Healthcare System, and the Bureau of Prisons. And this kind of gives you an idea of how those expenses were broken down. Again, Medicare, nothing we haven't talked about before. In terms of Medicare components, let's be sure we mention that one more time. A, B, C, and D. A is hospitalization. B is physician's office, ambulance, durable medical equipment. C is an HMO version of Medicare, so it combines A, B, and D, and may actually give you some other things as well. And then D is prescription drug benefit. A and B was created first. A was created in most cases to closely mirror what was being done in the Blue Cross world at that time. B was created in a way that closely mirrored what was done in the Blue Shield time. So if you see an analysis that says Medicare A closely resembles what, it should be Blue Cross. Medicare B closely resembles Blue Shield. And then Medicare C was created to give people an opportunity for an HMO variety of Medicare. And the advantage to that is, so Medicare typically doesn't cover these things unless it's part of a Part C program. Some Part C providers for Medicare provide some additional things that's not otherwise covered under Medicare. Again, Part A is financed by payroll taxes. And that's a benefit you receive once you turn 65 years of age, or if you're disabled or you develop end-stage renal disease. And other benefits, there's a small skilled nursing benefit. There's some home health benefits and hospice benefits. Hospice is non-terminal irreversible illness. And you actually, typically people are on hospice only for a couple of weeks. Most people do avoid trying to get into hospice and in denial of death being imminent. And so the typical duration of time people are on hospice is only about 2 weeks. But let's say you wind up being on hospice for a couple of months, and then for whatever reason, you don't die. That's a good thing. Well, it doesn't mean you lose your health benefit. They can actually recertify your hospice, or they can take you off of hospice. It doesn't really change your other coverage. The point is, if you're on hospice, don't worry about your coverage. You do need to talk to your doctor about being sure you stayed certified, and hopefully you live as long as you can in a healthy and quality of life sort of way. Let's see, what else do we want to talk about with Medicare? Part B, Medicare Part B is, again, physician services, outpatient care, diagnostic tests that are outside of the hospital. Diagnostic tests that are inside the hospital are tricky. It depends on how they're billed. And then durable medical equipment and ambulance. The best way to describe durable medical equipment, let's say I've had knee replacement surgery and I need a walker or I need a wheelchair, I'm eligible for that to be paid for through the DME component, Medicare Part B. Medicare Part B is an 80-20 plan, so Medicare A does not require a monthly premium. Medicare B does have an annual deductible and does require a monthly premium. It's a small premium, but when people talk about, well, I got a small raise on my Social Security, but all of that was eaten up by, they bumped up the cost of premium for Medicare Part B. And that's why Medicare Part C is really attractive, at least in some communities. Medicare Part C provided, particularly in Louisiana, there's a couple of providers here that offer a fairly wide array of services that are additional benefits that aren't normally provided through Medicare because of how they can operate a financially successful business, so to speak. And then Medicare Part D is the drug premium. Again, this was part of the Medicare Modernization Act of 2003 and does apply to those who have Part A and Part B. Medicaid, as I mentioned before, is financially disadvantaged. The CHIP program allowed them to expand the window of who was eligible for Medicaid type services targeting children. And then let's talk about reimbursement methods just a minute. Again, I'm just going to hit the highlights of this. The most common outside of the hospital is fee-for-service. So if I go to the doctor's office, I may get a small list of the things that I'm being billed for today, but that's typically a fee-for-service type approach. And the phrases are usual, customary, reasonable charges. And providers can balance bill of what the approved charges are. Again, what I mentioned before, the approved charges, not the gross charge, but the approved charge. Bundled billing is more along the lines of what we see in a hospital, and particularly, I think I've got it here in just a minute. Yes, resource-based relative value scale. So this is really the way Medicare pays for services today. In other words, if I had a stroke or a heart attack, what Medicare did was bundle the thousands and thousands and thousands of strokes in one group and heart attacks in another group and said it should cost approximately this amount of money to take care of that patient. And this is the time, the skill, and the intensity of care that we anticipate for each person who had a heart attack or each person who had a stroke. And if I'm Medicare, this is how much money I'm going to give you. There's some small variations because cost of labor is different in New Orleans than it is in Los Angeles. So there's some small variations, but primarily speaking, if I had a stroke in New Orleans and I had a stroke in Los Angeles, the hospital reimbursement is going to be about the same thing because of this resource-based relative value scale. Another piece is managed care. So the PPO that I mentioned earlier, PPO is a preferred provider organization. It's a part of, it was something the insurance companies came up with to combat the HMOs and maintain, offer people some discounts for using people within their network. But that's a discounted fee approach. If you use the doctors in my network and I'm the insurance company, I'll give you a discounted fee. Well, HMOs typically don't take that approach. HMOs are more likely to take a capitated approach, and that's a per member per month approach. And what that basically means is if I'm an HMO, it's Randy's HMO, I go to the doctor's office and I want to bring some doctors into my HMO, and I sign a contract with you that I've got 10,000 members and I want to give you $1 each month for all 10,000 members, but you got to take care of 1 or 100, however many show up, but you've got to take care of my 10,000 members. Chances are not 100 of them is going to show up each month, but that's the risk you take. And what I'm doing, that's called capitation. I'm transferring a lot of my risk from me to you. Now, some would say I wouldn't do that. Well, you know, if I'm the doctor's office and I'm getting $1 per member per month and there's 10,000 members, that means you're going to write me a check for $10,000 every month. Whether I see 1 or 100, you know, I'm going to get a check for $10,000. Well, guess what? Every month I got to pay the light bill. I got to pay the mortgage. I've got to pay my staff, whether I see 1 or 100 people. So it actually helps to have a little bit of capitated business because you know you've got that dedicated income coming in each month. Just understand the chances. Capitation means you, the doctor's office, have agreed to assume a lot more risk. And so that's the trade-off in working with an HMO. The advantage is you get a dedicated amount of money each month. The disadvantage is you could wind up spending all of that and then more if more people show up than you anticipate would show up. Retrospective reimbursement is something that we don't use nearly as much of anymore. This was how we once did things. There's still a component of this and that cost-based reimbursement. Each year, hospital files and nursing homes file their cost to charge ratio, their CCR report. And based on their CCR report, Medicare will give them some additional dollars. And that is some retrospective reimbursement. But that used to be how it was only done, and it led to some really out of control healthcare cost. Today, it's mostly prospective payment. The prospective payment system, again, started in 1981. It was phased in. Today, we see a number of different types of prospective payment systems. The DRG is the inpatient hospitalization system. The APC, the ambulatory payment classification, is outpatient. As I've mentioned the other night, ambulatory doesn't mean by ambulance. Ambulatory means I'm able to ambulate. I'm able to walk with assistance. Sometimes that can be a little confusing. The RUG is the Resource Utilization Group. That's for nursing homes. And HHRG is the Home Health Resource Group. And obviously it's for home health agencies. So as I mentioned before, the DRG is a bundled, based on a diagnosis, a bundled payment that I'm going to get for each patient who had a stroke. All of my strokes, I know what the bundle payment's going to be for everyone who had a stroke. That's a little bit more nuanced than that, but again, for the sake of comparisons, everyone who had a stroke, I'm going to get a bundle amount of money for that. Everyone who had a heart attack, I'm going to get a bundled amount of money for that. And so there has been some adjustment to it through the years to reflect severity of injury, and the Medicare severity of DRG is what's called MSDRG, but again, most people still call it a DRG. And this gives you an idea of how that payment diminishes. So if my DRG payment is approved for a 6-day stay, just understand that I can keep that patient in the hospital for 7, 8, 9, 10 days. But guess what? After day 6, I'm not getting anything else for that patient. So I need to figure out in 6 days if I can take care of you for the condition that you have. And the reality is, after day 4, it may cost me more than I'm getting in reimbursement to keep you there. So I may actually have an incentive to try and discharge you sooner than 6 days. I may have an incentive to discharge you after 3 days. But we'll talk about average length of stay later on, and that's a part of that context of why. The Medicare outpatient prospective payment system, as I mentioned, so this is based on APCs, and APCs are when you think about an ambulatory surgery or a day surgery, that's really where APCs apply. You know, if I'm going to have my gallbladder removed, or if I'm going to have some type of an option, I had my shoulder surgically repaired. All of those things typically happen at an outpatient surgery center. It's probably close to the hospital. It may be just down the street or across the street. But it's probably not attached to the hospital, primarily because of some reimbursement structures. But the ambulatory surgical center is paid through an ambulatory payment classification, an APC. The RUGs are reimbursement for skilled nursing or nursing facility care. Not a lot of need to go into the details of that, but just when you see RUGs, you need to think about reimbursement for skilled nursing. When you see HHRG, you need to think about reimbursement for home health. We've got an entire week dedicated to pay for performance and how that's linked to payment. The main point I'll make here is pay for performance. The main thing you want to remember about pay for performance is, earlier I mentioned cost-based reimbursement and that cost to charge ratio and that cost report. Just understand, although that's not, it still represents a big check. I mean, in some cases it could be $10 million, in some cases it could be $100 million, but pay for performance will adjust that check either up or down, a small sum, but just 1% of $100 million is still what, $1 million. So $1 million is a lot of money. So we will talk about this, and we'll talk about how this impacts reimbursement. We have a whole week dedicated to this. Now I want to pivot and talk just a little bit about managed care. I've mentioned this as we've kind of gone through this earlier. The main thing to remember about a managed care organization is they use a gatekeeper approach, where a primary care physician, usually your primary care physician, oversees most referrals. And the most common method for reimbursing providers is capitation. There could be discounted fees. In some cases, they own the facility and they pay salaries. But the number one most common way of managed care is through capitation, paid per member per month. Again, I'm an HMO. I come to you. I want to buy your service. You're the doctor's office. I got 10,000 members. I want to write you a check for $1 per member per month. That's a check for $10,000. All you have to do is just, if nobody shows up, You don't have to see anybody. I'm still going to write you the check. But if a lot of people show up, you have to see them all, and I'm still going to write you the check, and it's still going to be $10,000. So you don't want a lot of that business, but having a little bit of that business probably isn't a bad idea. As I mentioned before with the HMO versus the PPO, the HMO is typically a capitated model. It's state regulated, but it's typically not insurance. A PPO, on the other hand, though, is an insurance company that's looking for a way to provide some discounted fees, and certainly is state regulated by the Department of Insurance. The main point I'll make about accreditation and quality indicators, again, there's something called the Medicare STAR system. The point to the STAR system is to help you understand a 5-star hospital obviously has a higher quality of care than a 1-star hospital. A part of the STAR system also is to, we'll talk a little bit more about reward and the pay for performance week that we have coming up. And we'll talk a little bit more about quality indicators in the STAR system there. What else do we need to talk about? The one thing I would tell you about Medicaid expansion in Louisiana, it cut the uninsured in Louisiana in 2 years from 22 to 11%. It has made a world of difference to those who live in those underserved or poorly served areas. It also helps stabilize insurance. You know, just understand there's something called cost shifting, which basically means the best way to describe cost shifting is if I go to the hospital and I'm having an emergency condition, do they have a requirement to provide me care regardless of my ability to pay? And the answer is yes. That's called the Emergency Medical Treatment and Active Labor Act. Well, who's going to pay for that? If we took the Walmart analogy and I get to the checkout line and I'm hungry and my kids are hungry and I've got enough food to feed me and my kids, and I get to the end of the checkout line and I can't pay you, under EMTALA, if this was an EMTALA situation, Walmart would have to give me that food for free. Well, do you think Walmart's going to give me that food for free? It costs them something. Same way with the hospital, it costs them something to provide you care. So who do they transfer that cost to? They transfer that cost to everybody else standing in line. It's called cost shifting. So everybody that comes through the hospital receiving free care is really not free. They shift that cost to everybody with insurance. So the more people who have insurance, and even if the insurance is Medicaid, the more likely your insurance premium actually reflects what your insurance cost is, and is not reflecting the cost shifting that's had to go on because fewer people have insurance. And I've talked about the gatekeeper approach. The last thing I'll say about utilization control methods, prospective payment is pre-certification. Prospective utilization is pre-certifying somebody who may need some type of care, such as if I need gallbladder surgery, I may need to have it pre-certified to be sure that I'm getting it done at the right place at the right cost. Concurrent utilization is when it's being evaluated as the care is being provided, and retrospective utilization is where retrospectively they're looking back at what was spent, what was done, and should it be approved for payment. So let's kind of wrap it up with a couple of things. Again, finance is one of the most important things we do in healthcare. I'd love to tell you it doesn't matter. It absolutely matters. We have to have enough revenue to provide the services we provide, and we have to be good stewards of that revenue. And so we're going to do all we can to collect all the revenue we can in a way that is ethical and logical, and we're going to spend those dollars and invest those dollars if we're a good, again, if we're a good community-based healthcare system. And both LCMC Health and Ochsner Health are both community-based healthcare systems. They're going to reinvest those dollars in their healthcare system serving the community. That is their obligation. And so you know, but it's big business. In many states around the country, healthcare accounts for a healthcare system is the largest employer in 39 states now out of 50 states. Healthcare has become a huge business. As I mentioned earlier, we're the largest employment sector in the country of all business and industry now. So from an economic standpoint, that's a little scary to say, but from a healthcare management standpoint, that's the reality. And so we need to figure out going forward, what I would encourage you to do is think about what you want to be in your life and your career, and how much are you excited to know about finance. Finance is a big part of what we do in healthcare. The more you embrace this, the more you get to understand this, the more you know this, the more successful you'll be. You can be successful in healthcare without embracing finance, but the more you embrace and understand finance, the more successful you'll be. Anyway, at that point, I'll say thank you, and certainly if you have questions, let me know. Otherwise, I'll see you Monday night in class, room 122 at Kirschman Hall. And let me bring this to an end and stop that. Okay, have a good day.